Evening. Thank you, Jens. Thank you to the course directors for having me. I've always enjoyed all of my time at SSF. I apologize that my institution is not letting me be there in person, but I will do my best to put on a show as I would if I were in person. And so we'll get started. Yeah, thank you for having me as the inaugural, or as the kickoff speaker, so to speak. We'll be talking about some of my experience in returning to play in contact and non-contact sports after a cervical spine injury, such as a disc herniation. We'll talk about total disc arthroplasty, and then we'll go right into the case presentations after that. I have a couple of financial disclosures to list here. None of them are in any way pertinent to any of the topics talked about in my subsequent talk. But I do have a number of spine consultancies that deserve mention, including being one of the Northwestern team positions as far as spine issues are concerned. We also take care of the Cubs and the Blackhawks, and I'm involved with consultations with those groups, as well as serving as the head, neck, and spine medical committee member. And none of the opinions that I'm about to express are in any way representative of the organizations that I work with, and they are my own and my own only. The data revolution in athletics has been rampant, starting with baseball, proceeding to the three-point shot in basketball. In football, we're seeing dramatically different decisions on offense, secondary to the data and analytics. And even in hockey, we see a lot of different changes. And there's no reason that as a healthcare practitioner, all of us in the room can use this data to improve athlete safety, whether it's a professional athlete or an elite athlete in your practice, or even children who come, your own children, for example. We can use all of this data to show that we can improve outcomes in the long term. And one of the ways we can do this is that will help us is with cases like these. This individual came to me about 3 weeks ago. It was a collegiate starting running back, had 2 episodes of numbness and tingling in his arms and clumsiness after taking a hit. It was after further questioning when we found that he had a number of similar episodes in high school while playing football, but he was neurologically intact, he was full strength, he was on a full scholarship, he had NFL aspirations, a full range of motion, but then he has this cervical spine MRI demonstrating severe stenosis. And what do we do? He's asymptomatic, yet he had this transient quadriplegic episode. Do you tell him that he can't play? Do you offer him surgery? How do you manage this? And it's really with the limited data that we have that we can hope to help him. For those of you following the news now, Jacob Eichel is a all-star center for the Buffalo Sabres, who plays in the NHL hockey, who has a cervical disc herniation, who has basically demanded a cervical disc replacement. He does not want a fusion. He's taken his case to the media. The media has used the total disc arthroplasty case as saying that there's never been one done in a hockey player, which to my knowledge there never has been. And then asking the question whether or not this is the right procedure for him. And so again, we don't have any data on total disc arthroplasty in hockey players, but we can certainly try to use whatever data we have and make the best decision we can based on the clinical symptoms, the history, and the evidence that we have involved. Now, if COVID-19 has taught us anything, is that there are a number of levels of data that we need to keep into account when we make decisions on the public health in general. And this is no different when it comes to sports-related spine injuries. The only difference here is that when we talk about this problem, we really have no randomized controlled trial data. We never will, so you might as well throw that out the window. And I would also argue that the registry data on a league level is really not good enough. I am involved on this league level data, and many of the data that we have is limited because of the Players Association, because of de-identification rules, requirements, and so we're really relying our decisions based upon retrospective data, level 3 and level 4, as well as that of anecdotes. And, I'll be the first to admit that it's probably not going to get much better than that. Now, the number of clinical studies that we have to make decisions is much better in 2020 than it was around 1978 when we only had one clinical study. When Mike Utley came around for the Detroit Lions, there was 5 studies available. Kevin Everett came along, there were 16 at that time. And now, we're inching our way forward and we have better data, but still we have to try to make the best of what we have. And so at Northwestern for the last decade, we've been collecting data as part of the Sports Professional Orthopedic Research Tool. We've collected data for over 4,000 athletes in 15 different types of injuries. Spine obviously is a major part of that. And we've also published on a number of different sports, so we can compare outcomes in sports, whether it's American football, whether it's tennis. There are obviously different physical demands and different expected outcomes after each particular surgery. Now, this has led to my classification of sport a lot differently than when I came into practice. I now look at non-contact sports a certain way that are literally non-contact. But then there are also a faction of sports that are contact, but where the contact isn't an integral part of the daily grind, so to speak, like basketball, soccer, handball. These are sports where there is contact, but it's definitely different from a collision sport where I would use American football, hockey, rugby, and even skiing as an example for. And then finally, this rotational sport issue when it comes to baseball and golf and tennis, that really is a very important category as it pertains to lumbar spine for a different type of talk, obviously, but deserves this category of its own. As far as the athlete's cervical spine is concerned, there are many unanswered questions when it comes to return to play, when it comes to the right treatment, when it comes to algorithms. And this comes down to how do we treat a cervical disc herniation? What do we do with cervical stenosis? How about a pseudoarthrosis? When can we return them to play, as well as congenital anomalies? American football is a microcosm of its own, since this sport subjects its players to high velocity trauma. The spear tackler spine is a diagnosis that was born out of the physical demands from NFL football. And then this unnatural loading pattern action, hyperextension, axial loading, rapid rotation is really unique to this sport compared to the other sports that we see. And boy, have we come a long way. When I first published a study in 2010, now 12 years ago, that's about the time when Peyton Manning had his surgery. And at that point, we were asking whether or not collision athletes should have cervical surgery at all. And then when they did have the surgery, were they at risk of spinal cord injury afterwards? And then would you ever clear a football player after a cervical fusion? I mean, the first to admit that 12 years ago, 50% of the spine surgeons in the audience would say no, that they would not allow a player to get back to a collision sport after a cervical fusion. But clearly now, with our data that we have, it's a lot different. We've even shown that operative patients can actually get back at a higher rate, have a longer career than non-operative treatment from a cervical disc herniation. And then we've even shown here that there are certain positions on the field, again, as it pertains to American football, that predispose one to having a poor outcome. So if you're a defensive back that really requires range of motion at a very quick twitch type of scenario, as opposed to a quarterback who really can predetermine their motions, or an offensive lineman, your outcome after a cervical disc herniation is significantly different. And so this really represents the opportunity in which a total disc arthroplasty device could work. Because after a fusion, on any other position on the field, in my opinion, your career likely will not be shortened prematurely from a one-level ACDF. I think the data clearly shows that. Unless you're a defensive back or a linebacker or one of these other positions, and it's possible that the decreased range of motion from a one-level problem or a one-level surgery really is felt by that particular player and not the other players, which a total disc arthroplasty in theory could improve. The other evolution we've had in treating these athletes is with how to treat cervical stenosis. So in the 80s and the 90s, we only had CT scans and x-rays. MRIs have definitely revolutionized the way we can look at a spinal canal and determine what is safe and what is not safe. And more recently, over the past 5 to 7 years, we've become more aggressive at allowing players to get back as long as their clinical symptoms are absent and their MRI findings reach a certain threshold. Whether that's 8 millimeters or 10 millimeters, that's really up to the physician to decide. So we published this algorithm a couple of years ago in terms of how to manage cervical spine conditions and when to allow them to return to play. And it really depends on a couple of things: what kind of sport they play, what their imaging characteristics are. The issue with myomalacia, that's a different part of this talk, but whether or not that's an indication of permanent necrosis or is it reversible? What are the clinical symptoms? How severe was a transient quadriparetic episode versus something that just may be a stinger? And then finally, the physical examination. So those 4 criteria. So the next question is, well, which procedure? And so obviously the folks in the room know that not every cervical disc herniation is a candidate for a foraminotomy, right? So we got to make sure that it's the right disc herniation that we're thinking about. And then when it comes to a procedure that needs to be done from the front, what are the differences between a fusion and a disc arthroplasty? Unfortunately, we don't have a lot of data on this because we don't have a lot of data on cervical disc arthroplasty. I tried my best with this study that was published in Clinical Spine Surgery 6 years ago, where we looked at 101 athletes and compared the outcomes depending upon their 1-level cervical disc herniation and what surgery they had and what level they had. Again, we tried to do the best that we could with this. And so in this cohort, clearly the number of ACDFs far outnumbered every other procedure. But we were able to see some trends here that really have affected the way I counsel patients as to what procedure is best for them, depending on what sport they play and what they really want. Now, the reoperation rate is really important. Those who get a foraminotomy have a very, very much higher reoperation rate than any of the other procedures, in particular ACDF. You can see in the total disc arthroplasty group, there are only 2 athletes in our cohort, and both of these played Major League Baseball. We didn't have any other contact sports to really go by, but there are some in the literature that we can use. And in a nutshell, this study showed that if you have a foraminotomy, you actually have a higher rate of return, but also a higher rate of reoperation. Whereas in ACDF, you have a reasonable rate of return at about 71%, but a much lower reoperation rate during your career. And these are 2-year reoperations rates. For the total disc arthroplasty, these players actually did really well. But again, it's in baseball and we only have 2 individuals. So it's really hard to make any conclusions based upon that alone. But we do know that fusions fail us in certain situations. When does it fail us? Well, the young patient who develops adjacent segment degeneration just a year after an ACDF, that's a real bummer, especially if they're 42 years old. Are you going to fuse the next segment and subject them to another level of adjacent segment degeneration 2 years down the road? Probably not a great idea. Multi-level disease. Clearly, 2-level surgery versus 1-level surgery is different. And this is just one study from OBC. There are tons of other devices that have shown the same thing, that when you do compare 2-level patients, the numbers don't lie here. There's definitely more improvement with clinical outcomes as it compares to a 2-level disc arthroplasty versus a fusion. Much less so in a 1-level, in my opinion, as the literature has shown. But still, we got to look at the data and the patients that we're looking at. Skip pathology. This is a terrible problem for fusions, right? If you got C4-5 and C6-7 with a normal C5-6 disc, what are you gonna do with that? Well, maybe a laminoplasty, okay, but then you're treating like 4 levels with that. And then if you do a 2-level fusion, most people are just doing a 3-level fusion. So really not a great option here for fusion. Then there are risks for osteoarthrosis, smokers, immunosuppressive therapy. And then finally, it's the lead athlete who relies on the neck range of motion. Again, I'm kind of harping on this defensive back position. I think there are other positions in other sports that have a similar type of subcategory where we really got to look at what we can do as a surgeon to help prolong their career. And it's quite possible that a fusion would decrease range of motion, and where your job depends on batting away a ball that takes, 0.1 milliseconds to do with your reaction time, that could make a difference. Now, our database in particular, again, not robust. There's no database in the world that's robust, but it's important to point out the level of comfort that we have with a fusion versus a disc arthroplasty versus a foraminotomy. Again, the return to place rates are going to be different. But there are players who have had disc arthroplasty that have returned to a contact level of sport. And these cases are actually from Ron Lehman from Columbia Hospital and Clinics. There's a 21-year-old male who had recurrent stingers, weakness in the biceps, has a cervical disc herniation, a 1-level prestige ST disc. Again, this was done about like 7 or 8 years ago, and was able to return to the mat. Again, this is contact. It may not be American football, but it indicates some level of stability that we can go by to help counsel patients whether or not they are good candidates for this. Another individual, 28-year-old male who's in special forces, and these individuals obviously have are subject to a lot of different contact. 1-level problem, 1-level disc, prestige ST, and got back to full duty without any issues. And this has been supported by the literature, as you'll see. If you do a search on cervical total disc arthroplasty in the elite athlete, you're not going to find much. You find this one article talking about return to sports after disc replacement, where most of the athletes are runners. So I don't know if that really helps us a lot. And then finally, their arthroplasty in the military experience, a couple of studies that have shown that return to this type of contact is safe. Now, anecdotally, and this is where, the experience, and I've been invited on a number of different occasions by Jens all over the world, where we talk to surgeons in Europe, in South Africa, and all of these different parts of the world where they have done cervical disc arthroplasties for very active individuals, such as those who play in the professional rugby union. I think this means something. Now, none of it's published, which is really difficult to discern. But the more people you talk to in which there are anecdotes of players who have had a disc arthroplasty, 1-level, 2-level, who play rugby, who wrestle, who play NCAA football, this can build a cadre of evidence to at least help us determine whether or not are we ready for this next step when it comes to American football or any other sport. So the way I would look at total disc arthroplasty in the elite athlete is as so. On the pro side, you've got biomechanical testing. You've got these in goats where they ram their heads together. They do it all the time. None of it dislodges. There's stability there. We've got general patients who have been in a motor vehicle accident with a disc arthroplasty who have shown that there's no instability. There's clinical evidence in our general patient population to show that the rate of dislocation is very low. There's anecdotal evidence for these elite athletes, and there's general common sense. On the con side, the forces in American football are very unique, okay? And so it's really hard to recreate this with all of the pro arguments that we have. The second point is that NFL physicians are really wary of clearing any player right now with a disc arthroplasty. I would not say that none of them would say no, but if you're going to do this for a college athlete and they have NFL aspirations, you're really subjecting them to the possibility that they may not be cleared depending on who drafts them or who their team is. And then finally, do you want to be the first? So I really think that American football is different than any other sport. I think hockey athletes, I think tennis players, I think baseball players who have a disc arthroplasty, very low risk there. American football is a different animal. And do you want to be the first physician clearing somebody with this device in their neck and taking that liability? Again, that's up for everybody, or a debate for everybody who's in the room by themselves. So the take-home points here are that the outcomes from an ACDF and for amyotomy can be improved upon in this patient population. We've clearly established that depending on what position you play. Disc arthroplasty has been utilized in professional baseball athletes and competitive amateur athletes. And there really had been no safety issues in this cohort. But we're talking about less than 5 here. So there's not a lot of data here, but it stands to reason that it's stable based on the historical data that we have. If a disc arthroplasty is to be considered, in my opinion, an implant with immediate fixation really may be more optimal. Some of these other implants, second, third, fourth generation that have incorporation, I think may be reasonable, but you're really going to need a CT scan. You're going to need to wait a lot longer in order to release into place, especially with contact with helmet. And then finally, in my opinion, the disc arthroplasty may open up options for a 2-level problem. I think a 2-level fusion in most situations in American football will disqualify them. In my opinion, it does not, but there are a number of teams that will just automatically do that based on their protocols. So really, we're talking about making the correct decision based on the athlete-based literature, the general evidence, expert opinion, And then finally, what you see on exam and history in order to make a decision on a case-by-case basis. So to conclude, this data revolution really presents a wealth of opportunity for us as physicians, as trainers, as healthcare practitioners for player safety. We're shifting the questions that are being asked with the study design that we have. The considerations for the musculoskeletal conditions for the general population should be different than the elite athlete population, as we all know. Injury treatment should be individualized. We get a lot of players who come in our clinic and say, well, my colleague or my teammate had this procedure, so this is what I want. That's not what we should be thinking about, as physicians. Athlete treatment should be individualized, and finally use data and not dogma in order to make these decisions for everybody who comes to see you. Thank you very much. I'll stop sharing now.
Good stuff, Wellington. Receive the applause. I mean, really, very, very cool. Scott?
Thanks for that the excellent presentation. And it kind of goes to show that we kind of don't know more than we know at this point. But, I really appreciate you getting the data to kind of help build our knowledge base. And I think, interestingly enough, the press that this hockey player is getting about his decision-making and what's appropriate for return to play, it's going to come up with a football player at some point. And I think probably one of us in this room will eventually have to answer that question. My question is in the study that you looked at for foraminotomy versus arthroplasty versus fusion and the reoperate, what struck me is that really any different than the general population for those three operations? And that's kind of the question I want to put out to you in the panel.
Yeah, great question, Scott. And again, thanks for having me. I would say that the reoperation rate for a foraminotomy is much higher than the general population, at least from what we've seen in our studies. Now, there are some studies to show that the younger patient population in a large cohort has a higher reoperation rate, but we don't really know exactly what that means, how significant it is, what the percentage is. But if a player comes in and they want a foraminotomy, and I've had this before, I'm willing to do that as long as he or she knows that there's a 50% chance that we may have to do another operation in their playing career. And that's a big deal, in my opinion. And so, again, sometimes we come across a timeline where they need to get back within 4 weeks or within 5 weeks. And, that's when a fusion really doesn't make a lot of sense. And then you're like in season or versus, after the season. And so that has to come into it. But when I'm talking to a patient in the general population with a foraminotomy, I am not telling them there's a 50% chance they need another operation. I will tell them there's a higher chance than an ACDF. But 50% is a lot. 1 out of every 2, that just, for me, that doesn't necessarily breed out a successful outcome.
Yeah, and I agree. I think we see in our practice a higher percentage of patients who we do foraminotomies are on older, very kind of spondylitic, less mobile patients. And we don't do a lot of foraminotomies in younger patients. And that may be part of it as well. The other thing that, since this is a motion course, that I'd just like to bring up is as we gain more experience with different sports and doing cervical arthroplasty, the choice of prosthesis, because there are definitely biomechanical differences between the 7 or 8 or so prostheses that are now available in the US. And obviously this is early in all of our experience with athletes, but what's your feeling on those, and how do you kind of translate the biomechanics into what's appropriate for your individual patients, whether it be athlete or not?
Yeah, another great question. I think that's a next level question, in my opinion. I do believe that there's one characteristic of a device that I would use for a contact or a collision athlete. It would be one with immediate fixation. Now, I know those devices are not as popular now as they were when we first started doing this research. But having that fixation, in my opinion, especially if you're looking at clearing somebody within 6 months, without having the full I guess, the full confidence that you're going to have total 100% integration with the implate, with the device and the implate of the bone, you really want some kind of immediate fixation, in my opinion, if it's going to be your first patient that you're going to release to the field. So I think as far as the biomechanics are concerned with the bearing surfaces and how it translates, that really, we're just kind of talking about theoretical benefits here and how it applies to certain sports and such. But I don't think we have enough data to really opine on that at this point.
Wellington, it's Jack Ziegler. Thank you very much for the overview. I just want to tell you, I disagree with you about the immediate fixation, unless you want to send them back this coming Sunday, because all the devices really show pretty good integration without any clinical issues, certainly at 3 months, but maybe even before. So I'm not sure why you're harping on the immediate fixation since you're going to keep them out for a little while anyway. But just the general comment is it's really frustrating because, as we'll explore in this course over the next day, motion preservation is really very data driven. I mean, we have wonderful data on it, and it's going to be really hard to get data here when you have an N of 2. So like if the next guy who gets a disc replacement gets screwed up, then it's suddenly only 66% effective or 33% failure rate. So, it's going to be really hard to generate big enough numbers to get data that we can really rely on. So, just incredibly frustrating to not be able to use predictive analytics in this population when we can use it very successfully in a general population. But, I really appreciate your points.
Yeah, no, thank you, Jack. I think those are excellent points. I'll just address that immediate fixation issue here just now, is that we have data on how it's integrated for 3 months in the general population. We don't really know how it behaves in somebody who needs to put a helmet on. We don't really know how it behaves in somebody who plays golf, on a professional level. So that's why I think that immediate fixation would make me feel better to be the first individual to clear somebody in a professional sport, by doing that. So that's why I would say that. But you're right, though, Jack. I think there's enough data, and if we have really good imaging to show this integration occurs on a CT scan 3 months out, and that they can put their helmet on and use their head to spear somebody, then yeah, I'm all in on that. But as you indicated, we're not going to have that. We're never going to have that. But we may have a little bit here and there to allow us to move forward.
Hey, Wellington,
this is Christoph here.
Okay, Chris,
Jens, can I ask a quick question?
Yeah, go first.
Perfect. Hey, thank you so much. There's a terrific talk. I mean, I just wanted one comment regarding, ACDFs versus cervical foramen anatomies. The papers, the literature that I'm familiar with, you are right that the index level revision rate in foramen anatomies is higher, but the all-over revision rate is actually higher with ACDFs because you have adjacent level disease. So I think, all over the data is very clear that the revision at the index level is, definitely not more in favor of an ACDF, because you have to sum up the adjacent level too. And then number two is, that I think I agree with Jack on his comment that more restrained grafts are probably better in a more active, population. So there's, as there's some, cervical disc replacements that are unrestrained. And I think that's more problematic in more active, athlete sort of populations. So.
Yeah, great point, Christoph. The data that I showed was 2-year data. We're talking about 2-year data in the athlete population for reoperation rates. We're not really looking at adjacent segment degeneration there. But you're right, in the general population, when we look at 10, 15, 20-year data, you have to keep that into account for sure.
Hey, Wellington, so fan club here also, obviously. Great stuff. If there was a football player position in the NFL that would be a candidate for single level disc replacement, which position would that be? Don't say kicker.
Yeah, right. There you go. No, offensive lineman for sure. I think offensive linemen do well with anything. They're a different breed of the position. They sort of work through things. They don't really rely on their neck of range of motion as much as their low back, for example. I think that would be the perfect candidate. And I think we talked about that before. So yeah. So an offensive lineman came in, I'd probably clear him as I would Jacob Eichel after a one level issue for a cervical disc herniation going back. In terms of when to do it, what do you need a CT scan for integration? I mean, that we can argue till the cows come home, but I would certainly be comfortable with that.
Super. Okay. We have some cases prepared. Do you have time to join us still for a couple of case discussions?